Hi, this is Dr. Bhargava. In this short video, I have several interesting cases to share with you. This is our first patient. We performed a multiphasic CT of the liver, non-con, arterial phase, portal venous, and delayed. And we find that liver shows multifocal hypodensities that stay hypodense on all the three phases. And on the delayed phase, some of them show central necrosis. And so when there are multiple lesions of variable sizes in both lobes of the liver, the diagnosis most of the times is metastatic disease. Mets to the liver from most malignancies are hypodense like this on multiphasic study. Some tumors lead to hyperenhancing or hypervascular metastases. These include renal cell carcinoma, thyroid cancer, melanomas, and neuroendocrine tumors. This patient had a history of colon cancer, and these are Mets from a colon primary. This is our next patient. The finding was incidentally seen it's not the large left-sided pleural effusion that is also seen here, but the finding is in the apex of the left ventricle. You see how the myocardium here is very thin, and on top of that, there is this hypodensity that is attached to it, seen here on the coronal and also on the sagittal. So this patient has had prior myocardial infarction. As a result of that, the myocardium has thinned out and become an apical aneurysm, and on top of that, there is apical mural thrombus. So this is clotted blood that is attached to the apex because of stasis in this region, and this can lead to embolism, infarcts, and arterial vascular occlusions, things like that. Here is a patient who has had a gastric lap band. The position of the lap band is normal. The angle that it makes with the spine is normal. The lap band is usually just distal to the GE junction to create a proximal pouch that gives the patient a sense of satiety with a small amount of meal, and over a period of time they lose weight. Clearly it has not worked for this patient. They still are obese. The lap band is connected via a catheter to this subcutaneous port, and through this port saline can be injected to make this tighter around the stomach, or saline can be aspirated to make it loose or slightly looser around the stomach. Here's our next patient, and the study that has been performed here is Amyvid PET CT. I'm only showing you the PET images, where especially here on the axial image, the gray-white differentiation is lost. We see uptake in the gray matter and the white matter. So this patient has amyloid burden from Alzheimer's disease. On a normal or a negative scan, the gray-white differentiation is maintained, and there is uptake only in the white matter, not in the gray matter. This is our next patient. They came in with history of trauma, and here is the abnormality. The displaced rib fracture, because of which the pleura has been disrupted, and there is a pneumothorax on the right side. The interesting finding here is this part, which shows atelectasis. It's rounded, and we see the vessels in that fashion inside the atelectasis. So this is called rounded atelectasis. It's frequently seen with pleural diseases such as effusion, or sometimes with consolidation, or like in this patient with pneumothorax. Sometimes rounded atelectasis may persist and may seem like a tumor, and so instead of biopsy, a better scan to do would be an FDG PET CT scan, where, because it's not cancer, there will be no focal hypermetabolism, and then that can confidently say, that way we can confidently say that this is something benign such as rounded atelectasis. Here is another CT of the chest in a patient. If you look at this nodule in the lung window, you may not be able to figure out that this is calcified, but once you change the window to a soft tissue window, the hyperdensity or the calcification in the nodule pops up. And this is a trick I tell trainees to do whenever there's a lung nodule. Switch the window from lung window to soft tissue window to see the calcification better, and describe a nodule as a calcified granuloma, and then move on to the next finding. There's no need to measure this finding. All right, this is a young female who presented with abdominal pain, and on their CT we find this enhancing spiculated focus in the subcutaneous location abutting the abdominal wall in the left lower quadrant, seen like this on the coronal image and also on the sagittal image. This is a characteristic location for endometriosis, which is also called scar endometriosis from prior C-section. We see some scarring here. This is the horizontal incision. They make the Fannin steel incision for C-section. So some endometrial tissue at the time of the C-section surgery got deposited inadvertently in the abdominal wall, and now she has symptoms from scar endometriosis. This is our next patient. This patient had a renal tumor, a solid tumor that showed enhancement. So we said or diagnosed a renal cell carcinoma. They underwent ablation, and this is a post-ablation study. So you can find the T2 weighted axial image right there, the coronal image, and then DWI and ADC images, and then contrast enhanced images on the top, and a more delayed image on the right, a contrast enhanced T1 weighted fat saturated image again. And so here we find that at the site of the tumor there is a focus of hemorrhage, and there is some encapsulated fat. There is no true enhancement to suggest a residual or a recurrent tumor, and on follow-up we only see fat, and the hematoma has gone away. The hematoma would be variable on T2. It would be T1 bright and may show restricted diffusion. So this is an appearance of RCC post-ablation where there is no evidence of recurrence or residual disease. All right, another interesting patient, MR of the abdomen with and without contrast. The contrast enhanced images are on the top. The in and out of phase images are right here, and then we have DWI and ADC images. So the finding is not this focus of low signal, because this shows no enhancement on all sequences, and it shows high signal on DWI, and it does not show restricted diffusion. So that's probably a cyst. Now the interesting finding is this focus here, which shows low signal on in-phase image, and on out-of-phase image it becomes iso-intense, and on the pre-contrast enhanced image it slightly shows slightly high signal intensity on T1 weighted image compared to the surrounding liver. So this is a characteristic appearance of a siderotic nodule in a cirrhotic liver. The liver is cirrhotic because the surface has a nodular contour, the enhancement is very heterogeneous, and there are signs of portal hypertension that are not seen on these images. So something like this would be, if you're confident in calling it as a siderotic nodule based on what we talked about, you can give it an LR2. This is our next patient. They were suspected of having a vesicovaginal fistula, an abnormal communication between the urinary bladder and the vagina. They've had prior hysterectomy, so the vaginal cuff is where a communication was suspected, and instead of going retrograde or giving the contrast through the urethra and trying to see if it goes into the vagina, we performed a CT urogram. So the contrast was injected IV and delayed images were acquired. The delayed images showed distension of the urinary bladder and contrast transitioning or moving from the posterior aspect of the bladder into the vagina. Patient also has a Foley catheter that was placed and clamped so that the urinary bladder gets distended to make this contrast movement and the diagnosis easier. So a vesicovaginal fistula as seen on a CT urogram. This is our next patient. They presented with a adnexal mass, a young female. On the top, we have T2 weighted images in all three planes, which are essential. Also, they're in a small field of view when we are evaluating adnexal masses. And this is the focus we are trying to evaluate, a focus of high signal abutting the developing follicles in the ovary. So it's likely arising from the ovary. Here also it's seen as a part of the ovary, and right here. And that focus on T1 weighted images shows high signal, and on T1 fat saturated images shows drop in signal. So this focus contains fat, and a fat containing lesion in the adnexa is always a dermoid cyst or mature cystic teratoma. This is a contrast enhanced image showing no enhancement inside this fat containing tumor. So this is a benign tumor called dermoid cyst or a mature cystic teratoma. This patient was diagnosed with anal cancer, and a FDG PET-CT study was performed for whole body staging. And so you can see the cancer in the anal canal behind and posterior to the urinary bladder physiologic activity. There is a focus in the liver that is suspicious for metastatic disease to the liver. And there is a focus in the pelvis. So let's take a look at all of these three abnormalities on cross-sectional images. This is mural thickening and focal hypermetabolism in the anal canal, the primary anal squamous cell cancer. This is the focus in the liver, too small to be characterized on the non-contrast enhanced CT, but that focal hypermetabolism suggests that this is liver metastasis. And interestingly enough, this focus in the left side of the pelvis corresponds to this diverticulum with some surrounding fat stranding consistent with diverticulitis and the inflammation causing FDG uptake at this location. So metastatic anal squamous cell cancer with diverticulitis. Here is the sigmoid colon going that way, and there are other diverticuli also arising from it. And this diverticulum shows surrounding fat stranding and focal FDG uptake from inflammation, making the diagnosis of diverticulitis. Okay, FDG PET-CT study in a patient suspected of having Alzheimer's disease. I'm going to stop it right there and show you hypometabolism in a band-like fashion extending from the parietal to the temporal lobe on the right side with preserved uptake in the sensory motor cortex anterior to this line, and normal physiologic uptake in the visual cortex posterior to this line, right? And there is some hypometabolism involving the frontal lobe. All right, so I'm going to erase all of this and rotate this to the other side and show you the same finding of parieto-temporal hypometabolism in a band-like fashion with preserved sensory motor cortex, visual cortex, and the subcortical nuclei, involvement of the frontal lobe. So this patient has severe Alzheimer's disease, and the findings that I just talked about are characteristic of Alzheimer's disease on FDG PET. Okay, single sagittal view from a female pelvis, and this patient has ascites, so there is a lot of this free fluid anterior to the uterus, posterior to the uterus. Here is the endometrium that appears normal. This is a C-section scar seen in the lower anterior segment of the uterus, a Nabothian cyst in the cervix. This is the rectum and the anal canal. And so there is no abnormal finding here other than the ascites. And the interesting or the teaching aspect of this case is when the abdominal cavity is distended with fluid, you can look at and visualize peritoneal reflections better. So here we are looking at the peritoneum coming down like this line, and then it reflects off the urinary bladder, covers the anterior aspect of the uterus, goes down, and from here it goes this way, covering the anterior aspect of the rectum. So this focus is where it reflects from the uterus to the anterior wall of the rectum, and this is the site where it reflects from the bladder towards the uterus. So peritoneal reflections are better visualized when the patient has free fluid or ascites. All right, so another MR of the abdomen with and without contrast. Contrast enhanced images are on the top. DWI and ADC images are right there. In and out of phase images are on the bottom right. And on the left, I'm showing you T2 and T2 fat sat images. The finding is in the anterior aspect of the right lobe of the liver abutting the gallbladder. So this is bile in the gallbladder. The finding is seen as a focus of enhancement on the contrast enhanced images. But when we look at in and out of phase images, this is the in phase image, this is the out of phase image. On the out of phase image, most of the liver drops the signal. So there is hepatic steatosis, except for this focus, right? It does not drop signal. So putting everything together, that there is some apparent enhancement, there is some low signal on T2 and high signal on T2 fat sat. There is preserved signal on out of phase images, and there is no restricted diffusion. This focus is a focus of focal fat sparing. So the rest of the liver is infiltrated with fat, but this round focus is spared from fat infiltration. It's important to recognize these findings and not to call them pathologic and send them for biopsy. Okay, here's a HIDA scan. This patient has had prior trauma, and I will show you the CT later. But first we will start with the 1 hour images played as a cine from the HIDA scan. And as it plays as a cine loop, well, it stopped looping. So let me play it again. All right, so when it starts, we find that there is a photopenic defect at the dome of the liver, right? And as we follow the activity, there is excretion from the liver to the gallbladder and small bowel. All that is normal. And as we go towards the end, we find that some activity accumulates in that defect in the liver, and so there is bile leak into a hepatic laceration. All right, so here's the first image where I was trying to show you the laceration, and it's photopenic because there is hematoma there. There's no liver tissue there, and it fills up with bile on the delayed image because the bile has leaked into that laceration and the hematoma. Here is the patient CT showing this liver laceration, and that corresponds very well to bile leak into that laceration. So a small bile leak like that would heal by itself and no intervention is needed. All right, so switching gears to look at some DEXA scans. Here we have a patient where we are trying to evaluate them for osteoporosis. And when we look at their lumbar vertebral bodies, they've been labeled correctly. And we find that T1 and T2 are significantly different from L1 and L2 are significantly different from L3 and L4. When we look at L3 and L4, we find that there is degenerative sclerosis. So if I'm reading this, I will not include L3 and L4 because of degenerative sclerosis and significant difference in T-scores from other vertebral bodies. When we look at just L1 and L2, the T-score corresponds to what we see in the left hip neck region. All right, so here is another page from their analysis, and we find that if we include just L1 and L2 in our analysis, their T-score will be minus 2.5, and that would make them osteoporotic. So the teaching point here is when you see abnormalities in certain vertebral bodies, in that situation, you can exclude those vertebral bodies from analysis and use other vertebral bodies to make a better diagnosis. So here we call osteoporosis, and we know, as we saw earlier, that the hip region showed osteopenia. More images from the same patient showing degenerative sclerosis, and all of these artifacts that the technologists are trying to remove or black out from the analysis. These from a prior plain film turned out to be pellets from a BB gun, and they were shot at in the past, and all of these pellets are lodged in the subcutaneous and soft tissues of the right side of the abdomen. So if there are any that overlap the vertebral bodies, like right there, they have the potential to increase the bone mineral density, and they cannot be all removed manually and not counted towards this vertebral body bone mineral density. All right, so another MR of the abdomen with and without contrast. These are contrast enhanced images. These are DWI and ADC images. T2 weighted image, T2 coronal image showing a T2 heterogeneously hyperintense lesion in the liver. In the spleen. And this focus is seen like this on the pre-contrast. This is arterial phase, portal venous phase, and delayed phase. And as you can see, over a period of time, it fills in. And so this is most likely a hemangioma. Hemangiomas are also T2 bright, and hemangiomas will not show restricted diffusion. All right, another DEXA scan. Here again, we find that the L1 vertebral body has an abnormality. It looks like they've had a prior vertebroplasty before, because of which there is very high T-score and bone mineral density of this vertebral body. We definitely want to exclude that and report L2 to L4. So here is the more data showing L2 to L4. And so this patient's BMD is in the osteopenic range, although they probably have osteoporosis because they have had an insufficiency fracture that was treated with vertebroplasty. Okay, CT study of the head and neck region showing a lytic lesion in the proximal mandible on the right side. Look at the mandible on the left side. This lytic lesion presented as a swelling on the right side of the face, and they had a percutaneous biopsy after the CT that showed a plasmacytoma, and a FDG PET CT scan was performed to look for any other lesions related to multiple myeloma in their whole body. And so that's the only lesion that shows focal hypermetabolism, and there is no other multiple myeloma related lesion in their whole body. So that's an indication for doing a whole body FDG PET CT to look for additional lesions or whole body staging of multiple myeloma. Thank you for watching.